your car. The second thing that we cannot divorce from the word survivorship is caregiving. And this is any person who has cared for a loved one or has cared for someone going through a cancer diagnostics. Now, if we can pause there for a minute, again, do clinicians qualify as caregivers? In my perception and in my opinion, clinicians are the first port of call in the survivorship journey, because the moment diagnosis is made, that's where the clinician comes in. And I must commend Kehpca for having taken the journey of cancer care and palliative care in Kenya to the next level, because in essence, palliative care is also a way of improving as we are going into survivorship to ensure that the needs of the patient are taken care of from the word go at the diagnosis. Now, with survivors and caregivers, when I mentioned that we have a person who has cared for a loved one with cancer, and when I mentioned that it's either starting with diagnosis and moving onwards, either having no signs or symptoms of cancer after finishing treatment, or living with, through, and beyond cancer, we have to think about the lived experiences, both at the diagnostics level, at the treatment level, and beyond that, when they reintegrate back to the community. Some people who have gone through cancer survivorship mention that the moment cancer is diagnosed, there is shock, disbelief, anxiety, anger, grief, loss, pain, because often in our communities, it is assumed that cancer is a death sentence. But there is another side of cancer that is often not talked about. Many cancer patients and survivors have mentioned that they found their purpose the moment cancer was diagnosed, that they found a new lease on life because it's a second chance to live more deliberately. And it is also an opportunity to examine what has been going on with their life. So there is the anticipation of life beyond cancer. But then comes in the element of self-doubt, because there is this thing of, has the cancer really gone? Will it recur? What choices do they need to start making? What about recovery? Is recovery the end of treatment, or will there be other follow-on treatments that will be required, tests and diagnostics that will be required? And because life is lived forwards, understood backwards, it's only when the survivor, it's only when the caregiver looks back at the journey they've been, that they're able to say the lived experience has prepared them for the next course of action that needs to be taken. Now, for the clinician, on the other hand, people assume that it's often very easy for the clinician because they just think the roadmap for treatment, the care plan for the patient, keeping good records, and sensitizing the patient towards a new normal. But in Kenya, for example, we have a health system that is mired with late presentation. Often, our patients present late. And before we start blaming the patients and saying they're presenting late because they didn't know, we also need to think about what they've experienced in that healthcare system from the moment they started having some inkling or some feeling that something is wrong in the body, to the point where they land at the hospital, where they have to go through 9 clinicians before they actually get a diagnosis that this could be cancer. And because high costs of treatment means there could also be delays in finding the resources to be able to be treated. The poor access to services, some people have to travel long distances for them to be able to come and meet the clinician, the specialist who will be able to treat them. It means that for this patient who has been diagnosed, who is now a survivor, and for their loved ones who are the caregivers, there is a lot to also deal with. So by the time they land to the clinician, they could also be very angry at the healthcare system. They meet a healthcare person who has to deal with very many patients at the same time. And so the time spent with the patient may not be as much in terms of sensitizing the patient, in terms of sensitizing the family on what needs to be done. Regrettably, because in our government scenario, cancer care is not necessarily the highest funded. There is always the issue of financial toxicity that we'll talk about as we go along. And what happens with the clinician's role then is eroded trust. And I must pause there for a minute just for that to sink in, because often when we in the community, as a community health volunteer, community health advocate, or even cancer patient or caregiver, when we listen to the stories, often it's very easy to start saying the doctors don't care. But the truth of the matter is the doctor is also a caregiver. The doctor is also faced with a lot, and especially in the African setting. And with that, faced with a lot, and we're not just dealing with cancer, there are other non-communicable diseases, and there are other communicable diseases as well. And then there is COVID-19 right now. The healthcare worker is also very overstretched. And therefore, the trust issue is a two-way scenario that we need to address today. When Esther, you asked me to speak and to bring patients' voices to this conversation, I thought of three patients. And I've put 3 question marks there because I want us to reflect on these 3 patients. We'll call the first one Martha, the second one Otieno, and the third one Wanjiku. And because we have international participants as well. Martha would be any common woman's name. Otieno is a cultural name from the Lake region, Wanjiku from the Central region, and therefore one is a man, 2 are ladies. Let's start with Martha. And the story of Martha is she works in a corporate job. She has a good income. She has insurance. The company is paying for her, and NHIF is topping up where it needs to. So when the diagnosis for Martha came, Martha just has to think about her treatment, getting better and getting back to work, because finances is not a big issue for her. However, Martha has to still think about the anxiety, the shock, the disbelief. If it's breast cancer, the loss of a body organ, if she has to be to go through a mastectomy. She also has to think about anger and grief and loss, because she's thinking, how will I cope with this at the workplace? When Martha goes back to work, she faces a human resource person who doesn't necessarily understand that Martha will need to continuously go for tests. And so whenever she asks for leave, she's told, I thought your cancer is over, and yet you keep asking for leave to go for medical attention. Should we be concerned? The human resource person is looking at the bottom line and thinking work productivity, and also thinking, if the cancer recurs, will we be able to afford this treatment again? Let's switch gears for a minute. Otieno. Otieno is a man, married with children. And Otieno has been working as a truck driver. So he has a job. But because the cancer was discovered on the leg, right leg to be specific, and he has to go through radical surgery for him to be treated, regrettably, he loses his job. And when he loses his job, not only does he lose a livelihood, he loses his source of esteem in the community as a man who provides for his family. He also has to consider his children who are going to school, his wife who has to take care of him, and regrettably, the journey starts for him to start selling his property, the few items that he had gathered together as his savings for him to get treated. And remember, the only skill that Otieno has is truck driving, and he's lost the leg. How will he start a new life to go ahead and start fending for his family beyond the treatment? How will Otieno reintegrate into the community? The only life he knew was truck driving from Mombasa through to the port of Kisumu to deliver. And now he cannot do that anymore because we don't have that many trucks that are automatic for people with disability. Let's switch gears a little bit to Wanjiku. Wanjiku is also married. And the moment cancer came knocking, the husband got a new spouse. And with the new spouse came new responsibilities for the spouse. And because of that, Wanjiku has been left in a situation where she's a single mother with a cancer diagnosis, with an NHIF that was in the husband's name. So she has to start thinking, where will treatment come from? And she also has to seek treatment. Think about her children's education, think about her quality of life, and think about how will she progress going forward. The good thing about these three patients is that they actually survive through the healthcare system, they get treated, and they are now back to their life. People would tell them, go back to your normal, but is it really normal? If we think about normal quality of life, you would be thinking about that these three patients would have optimal physical, psychological, which is mental, spiritual, social, as well as financial well-being. And these are the 4 parameters that are usually used globally to measure quality of life in cancer survivorship. Regrettably, the stories that I've given, as much as the names have been changed, are actually an everyday happening. For example, if we think about the treatments that we give as clinicians, that are given by clinicians, if we think about the records that are kept for this patient, if we think about the distances they have to travel, the care plan that is given after that will mean that if Otieno is all the way in the Lake region, for him to be seen by the oncologist, will have to come back to Nairobi. That's quite a distance. If we think about the physical, that he has to start a new normal, thinking about quality of life, thinking about working, the physical element has to be considered in terms of what has been provided for him. When we think about the mental anguish I talked about earlier, and we start thinking about the psychological care of the patients over and above the treatment, during treatment, and the counseling they receive, they also have to start thinking about how will life be beyond. And of course, there is always the questioning of God or the higher power that they believe in, that was this worth it? How can I use this to be better able to inspire others? And socially, the acceptance. For example, when you talk of Wanjiku and the family breakdown because the spouse has left her, and all of a sudden her social equity is lost, her financial well-being is compromised, and there is the stigma of the woman who is living with cancer. The question we need to be asking ourselves is, in Africa, we have the double burden of communicable and uncommunicable diseases. Is this only relevant to cancer care, or is it also relevant to other diseases as well? Secondly, if we think about high-income countries versus our African countries, I'll give you an example. We know for a fact that today there are about 16.9 million cancer survivors in the US alone. That is because there is research to show how many people are surviving the disease and are living quality life beyond the treatment. In Kenya, I have to extrapolate and say 42,000 diagnostics every year, 28,000 cancer deaths every year. So we are talking of 14,000 survivors every year. But because we don't have data that shows how many have survived for the 5-year period, or how many have had a recurrence, or how many are going through the system in terms of treatment, it is not easy to plan. In the high-income countries, what you find is very well-defined advocacy units. Like, for example, the American Cancer Society, very well-defined, working with survivors and caregivers to bring advocacy, which is patient-centered. There is a culture of practice where there is multidisciplinary approaches to cancer care, so that when somebody is diagnosed with cancer, has been treated, when they go back to their primary caregiver at the community level, in terms of their community healthcare system, they will be better able to understand how this person should be constantly followed up. And the healthcare system is providing for that. Do we have that here? There is also the option of clinical trials. When there is a recurrence in the US, you'll find a patient is told, you can also get on this clinical trial This is the drug. These are the possible side effects. This is what it is anticipated it will do for you. Would you like to join in? Because if you join in, we will also be able to monitor you. We will see what is happening with your body, and it will inform future drug interactions so that we can make it better for our patients. In Africa, do we even have that? And so what you see in high-income countries is teamwork between the clinician, the patient, the caregiver. The healthcare system is wired in such a way that it is serving the people. What you see is a lot of advocacy. You'll find people in their parliament, in their policy-making bodies, advocating for the rights of caregivers and patients, advocating for budgetary allocations, and ultimately you get policy outcomes that serve the people. What about in our region? What we are seeing right now is younger people getting diagnosed with diseases that were touted to be for older persons. For example, we have girls as young as 18 years old to 24 years old being diagnosed with cervical cancer, early stage. Or we have girls as early as 23 years old being diagnosed with breast cancer. And yet we are told that policy-wise, we should have the first mammogram at 40. What can we do to change that? The second one is late diagnosis. And I mentioned this earlier, that we have late diagnosis of our patients stage 3, stage 4, when really what we're being told is what we can do is palliative care, or there is not much we can do towards recovery. And regrettably, these are women who could, if had been discovered early, could be treated earlier. Because we don't have universal population-based screening, again, the late diagnosis is exacerbated. And because we don't know about post-treatment care as much, or if we do, the healthcare system is not providing, we have recurrences. So the question is, how do we address the poverty that comes with cancer, the stigma that comes with cancer, the work dissatisfaction that comes with cancer, the poor outcomes with a poor healthcare system that's not building for our patients? How do we provide for all this? One of the things I want to draw our attention to is guidelines. And I know Kehpca is working very hard towards having a palliative care guideline. And with this, it's about providing a standard of care in palliative care. Can we also think about extending this to standard for survivorship care? For example, I know ASCO has very detailed post-treatment care documentation, as well as guidelines that can be adapted to our local region. The same with the NCCN guidelines for Sub-Saharan Africa on survivorship. I would recommend for the people on this call to also go ahead and look at it. But the common themes that come out of this is that we have to think about education, both for the healthcare professional, and by this I mean, beyond the clinical team, the specialists, let's also look at our healthcare workers in the level 1, level 2, level 3, also being sensitized to cancer, so that there is downstaging of disease, but there is also better quality care for people who are living with cancer, so that they can go to the facility at any one time and be able to receive the same kind of treatment that they would receive in Nairobi. Psychosocial support. I cannot overemphasize enough that mental wellness actually has a big bearing on the kind of survivorship quality of care that we would have for our patients. Long-term treatment complications, you know them. We have issues to do with physical fitness, issues to do with mental wellness, issues to do with even fatigue, things that would be addressed from a psychosocial perspective, and things that would affect the quality of care. Like, for example, when we talked about Otieno, the person who had leg cancer. And then we have to think about body image. Nobody talks about as much sexual health of our patients after they've been diagnosed. And some of the questions we get asked in Kilele is it even safe to continue having intercourse? Is it even recommended? How do I get to undress in front of someone who knew me with 2 breasts and now they know me as 1 or none? How do we handle that body image element? Fertility. When I came into the survivorship field, I did not even know that there was the option of freezing of the ovum, so that if a woman wanted future children, they can be better able to get them. But now the thing is, even if there was that intervention, can our patients afford them? The lifestyle modifications in terms of how do they live their life beyond this diagnosis? What is the right diet, the right exercise? Who can they consult in this field? And at the end of the day, whose role is it to provide for all this, which I call the rights-based approach? And in all these common themes, without sounding like I'm preaching, we need to think about, why do we practice medicine? Why are we in this field? It is for that patient. So if their needs are not being met, is it the role of the clinician to advocate for the rights of the patient, or is it the role of the patient to advocate for themselves? Will it be the community that will demand the government to meet the needs? Whose role is it? And so, before I get to Kilele Health Association, if we can pause for a moment and think about ourselves with the different hats that we wear. When I was asked to present on cancer survivorship, it was to try and open our thinking around the clinicians on the call. What role can we play? The patients on the call, what role can we play? The community members who are watching from social media or any other live links on this call today, whose role is it to ensure that we are advocating for our patients? Let me say this. The more we read about what is happening globally, the more I'm convinced that we have the means, the resources, and even the ability to be able to fast track the work that we're doing for better survivorship care. Why do I say this? Because they say knowledge is power, but I beg to differ. Knowledge is power only if we use it for the right means. So if we know there is survivorship care, how can we take it back and use it in our region to be better able to bring better outcomes for our patients? The ideal would be that in survivorship, we have the oncologist, the clinician, the family doctor, the community health worker, all of us working together with the patient for better outcomes for the future. But some of the barriers that we encounter in Kilele is health records. And in the today where we have digital capacities, that we can be on a call with someone from India, we can be on a call with someone from Rwanda, Burundi, today, this evening. How about we fast track that digital record keeping so that we are able to keep the records for the patients, but also the future follow-up, and also fast track to have maybe a call center that allows for tracking of these patients so that they don't lose to follow-up, so that they are better able to be managed and prevent recurrences. The second one is financial empowerment. How can we, as practitioners, ensure that our healthcare system is serving our people? I'll give you an example of 2 very different cases. One patient coming to Kehpca Hospital because the treatment is urgent and requires to be a surgery. They're able to book the private wing and get that surgery done as quickly as possible. NHIF will not cover the surgery. However, they will be better able to be treated because the family can afford it. The other patient comes to Kehpca, cannot afford that treatment, but because in private wing, so has to go through the mainstream Kehpca Hospital. And in that treatment, they have a waiting line for 6 months. None of us have a contract with cancer that you'll post for 6 months so that I get treated at the time that is available. How can we ensure that financial barriers do not become an issue for treatment for our patients? The third one is attitudes. Some of our patients and survivors have mentioned that when they go to the clinician and ask questions, they are called expert patients. Some of them have said when they go to the doctor's office and want to navigate another patient, and therefore they are asking questions, they are told they have too much, or they have spoken too much, or they have too much, how would I say, attitude. And yet, if we think about it, because of their lived experience, they could be a partner in that conversation. The third one is, and I spoke about this as a barrier earlier, is the challenge that we have of the time that the doctor can spend with that patient. The question is, if the patient and the doctor can only spend a limited time, who will fill the gap to be able to educate the survivor on post-treatment care, on future follow-up, and also to ensure that they maintain their survivorship for the longest time period, but they are sensitive to possibility of a recurrence and therefore can arrest it as early as possible. I would like us to switch gears briefly, and I'll talk about Kilele Health Association. Kilele is a Swahili word. It means to top or to peak or to summit. And it comes from climbing mountains, literally. So you'll see from our logo, we have the Kilele Challenge, which is a mountain. And we say that cancer is yet another mountain we have to surmount, because we see the cancer journey as an inner struggle, an external struggle to fight the disease, but also a community affair for us to be able to sensitize people about cancer. And we see a future where in Africa and other low and middle income countries, patients thrive in a more inclusive, equitable world, and the survivors can use their lived experience to drive change towards prevention. And as I've mentioned, cancer is yet another challenge to be overcome. We have 4 pillars, which is the first one is the physical pillar, where we look at quality of life. How well do our survivors reintegrate back to the community after they are diagnosed, treated, and told go back to your normal? The second one is the mental wellness, where we look at our members engaging with the community to be better able to mentally strengthen their approach towards health and also mentor others towards better approaches to quality of life. The community outreach pillar, which is about prevention and which is about sensitizing the community using the lived experiences so that the community can also embrace prevention. And the fourth one is financial wellness, where we're looking at empowering our survivors with the knowledge, the skill, and even some seed capital to start income generating activities, and especially cancer survivors who would fall in the category of Otieno or Wanjiku that I mentioned earlier. And so why we're doing this is to see cancer survivors as community ambassadors for elimination, where we're looking at policy engagement that the survivors can use their lived experience to ask for concrete decisions from our policymakers, to engage mainstream media with lived experiences, and also to tell stories on social media for impact so that they can continuously change perception on survivorship, not as a death sentence, but as quality of life beyond the cancer. If I can take you through, sorry, I will not mention, but we are members of the UICC, IPVS, as well as NCD Alliance in Kenya. And we have partners including pharmaceutical, government of Kenya, organizations, as well as private companies that support us in our work. And so if I was to mention some of the things that we've done in Kilele, in 2020, we had the big vision of climbing Mount Kenya, and we did. And it has become an annual program. When we started with physical fitness, it was to ensure better quality of life, but also to ensure we are engaging our survivors in activities that would give them dignity, quality of life, but also engage them in terms of ensuring that they are promoting a quality lifestyle with programs that promote physical fitness. And we started with also hiking, which brings resilience, and for them to also be able to have resilience to build purposeful living, to build quality physical fitness, and also to build mental wellness. And as you can see, those are some of the things that we've been doing since 2020, climbing hills, hiking hills, learning about cancer as we do so, advocacy training, as well as the symposium, which is what Esther mentioned a bit earlier, which is our platform to showcase what can be done in survivorship in Africa. And of course, they climb every year up Mount Kenya on the same dates, 20th to 24th of September. It's happening again. And why it's happening again is because with the survivorship journey that we took 2020, we had quite a bit of our survivors engaged in advocacy, both on mainstream media as well as social media, telling their stories to change the perception that there is life beyond a cancer diagnosis. Secondly, we had personal achievement. The survivors going up Mount Kenya, when everybody is saying it cannot be done, really was a personal proof that there is life beyond a cancer diagnosis. Thirdly, we kickstarted the conversation for people to start talking about survivorship. Fourth, we also kickstarted the conversation for people to start examining, and this has spiraled to many survivorship groups also looking at how can we engage survivors for meaningful engagement, but also for better quality of life. Lastly, there was quite a bit of personal reported outcomes. For example, sleeping better, less pain, less fatigue, better ability to handle their personal life. And with that in mind, we say that we're going to do it again in 2021. We will share with you our calendar of activities for 2021. But key things that you should note is that we have the 26th of August, which is our survivorship symposium, Kilele Health Symposium 2021. And I would encourage each one of you to come and listen to the various speakers that we have that will speak on policy, as well as harnessing the power of survivorship as a tool towards prevention. Secondly, we have an ongoing platform with Avinom Lana. He's a trauma specialist from the US who is taking our survivors, some of our survivors, through an 8-week online program for cancer wellness and recovery. And we also have the personal coaching and personal navigation program where we work with survivors who are going through treatment to ensure that they are actually getting the right treatment, asking the right questions, and also getting the right treatment and post-treatment care. Then we have community outreaches where we intend to continue with the community awareness and education, and in partnership with various government agencies for us to take the voice of the survivor to the community. And of course, we have the Kilele Health Symposium that I've mentioned. All these things that we are doing are towards meaningful engagement with the survivors as community outreach ambassadors. Is it doable? Yes. Have we shown it can be done? Definitely. Will you join us in doing it? I hope so, because what we've proven with the Kilele Challenge is that quality of life among us cancer survivors can be significantly improved with appropriate programming. The second thing that we've proved is that we can improve quality of life by involving the survivors themselves and educating them on the things that they can do to increase better quality of life. Thirdly, we're showing that it's easier for a lived experience to be shared than we ourselves being the ones who are speaking. That is why when Esther mentioned in my introduction that we are looking at meaningful engagement for survivor-led advocacy, it's because it has implications for clinical practice. If we want our governments and if we want our county governments to invest in quality care, it has to come from the person who has worn the shoe, walked the distance, and actually proven that it can be done. Secondly, for the clinician, better understanding of a patient makes better understanding of the care plan. If the patient is being advised that now we need to go to home-based care as opposed to hospital-based care, a patient will be better able to understand that if they get to understand why that definition of home-based care, because often, regrettably, when the patients are told it's about palliative care, it's considered that they are being sent home because there is nothing else that can be done in the hospital setting, not recognizing that empowering the patient will also help them make better decisions in terms of their care. And lastly, I would appeal to all of us who are listening in here that we start thinking about what are the research implications on survivorship, and how can we start generating evidence base to ensure that, one, we're reducing stigma, two, we're improving health outcomes, and three, we are making changes to the healthcare system that can be better serve our patients and survivors towards the long term. As a caregiver, it would also make my life easier and the life of other caregivers, because then we know we are all working together as a team. I think, Esther, I would like to pause there and request if we have any questions or any points of clarification. Thank you. Are we still on?
Thank you. Thank you. Thank you so much, Brenda. Thank you for the great conversation that we've just had, and highlighting key issues around survivorship. I think my take home, survivorship is not limited just to cancer. We are looking at all hard to cure conditions, so to say. Cancer is just one of them. It's just that the burden of cancer has really been growing, and we all know, or we've interacted with someone who's had a diagnosis of cancer, and we've had the experiences that the patients go through. And to add to what Brenda mentioned, we also commemorate the National Cancer Survivors Day, I think first Sunday of June every year. And in Kenya, we also, that event is marked nationally, led by the Ministry of Health, and we also have the Kenya Network of Cancer Organizations, as well as other cancer organizations in Kenya. I think there are questions that have come up as the chat is, as the conversation is going on. So in the chat, maybe I'll just highlight what has come through, Brenda, and you could see if you're able to respond to some of this. And also to acknowledge, we have a number of, or rather a good variety of people who are joining in, from patients, survivors, caregivers, healthcare workers, consultants, students also joining in. Yeah, so there was a question from a few comments, and there's a question about, maybe Brenda, you could just come again on who is a survivor. So someone asks, if a person is declared by the oncologist that he or she is free from cancer, we say that he's a cancer survivor. But if he or she is still on medication and even relapse appears, do we call them a survivor?
Yes, thank you so much for that question, Esther. I will stop sharing now so that we can have a dialogue with the participants. Yes, if someone has gone through a cancer journey, no matter at what stage, they are survivors. And I'll tell you, according to the American Society for Clinical Oncologists, there are 3 different types of cancer survivorship. There is the acute survivorship, which starts at diagnosis and goes on through the initial end of the initial treatment. So that's what you would be referring to as acute survivorship. At that moment, we are focusing on cancer treatment. There is the extended survivorship that starts at the end of the initial treatment, then goes on for months after, dealing with the side effects of treatment, dealing with the issues to do with quality of life, and the focus there is on quality of life beyond treatment. Then there is permanent survivorship, whereby we're talking about after the person has been treated, they've been told there is you're cancer-free and you can go on with your life. That's why we get to the point of permanent survivorship. Now, the question that has been asked about who is really a survivor is, that when we get the extended or the permanent survivorship, if there was a recurrence, if someone goes through a recurrence in cancer, they would now move from the permanent or extended back to acute survivorship, because we started focusing again on treatment. So from the moment of diagnosis, that person is a survivor. From the moment of diagnosis, the people who are taking care of that person, they are caregivers, because the status will only change from recurrence back to active treatment, acute survivorship, to extended and beyond. And if I can just build a little bit on that context, when we come to permanent survivorship, we also need to think about post-treatment, extended survivorship, quality of life. For example, someone who has, I know of a person, and they could be on this call actually, who has gone through the treatment of the nasal, post-nasal, and also the throat area. So with the treatment, the radiation, many years later, they are told you have hearing loss. Remember, when they were treated, they were younger. Many years later, they have hearing loss. Do we say that that is a new condition, or is it a post-treatment condition that has come on as part of their survivorship journey? It's not cancer that has recurred, but it's a post-treatment side effect that has recurred. Shouldn't that also be managed? And therein comes the cost of treatment beyond the treatment, that they will need a hearing aid, they will need batteries for that hearing aid, they will need constant checks to ensure that that hearing aid is still serving them. And I can go on. Prosthetics for women with living with breast cancer, prosthetics with people who have lost a limb to cancer. We have to think about post-treatment conditions, like, for example, if someone has a heart pacer because some of the drugs that were given affected their heart condition. That is part of survivorship. I think in definition, survivorship is from the moment of diagnosis, and beyond that, then we can classify it as acute, extended, or permanent survivorship. Thank you, Esther.
Thank you for that explanation. And you've also touched on the bit that survivorship would also be applicable for children. So it's not just the adult with colorectal carcinoma. Yes. There's the child who had the postnasal space tumor, and now they've grown up and they have these issues coming up. So they need to be followed up and care given as appropriate. The other question was about the coaching program you mentioned. Someone asks about the costs.
Okay, so we have the program, especially the one that we're going through with Avinom Learner. It's a program that's pretty expensive. If someone was to go separately of themselves, we are talking about we're talking about $50,000 US. Sorry, $5,000 US for the program. $5,000 US for the program per person. But with Kilele, we have a partnership with Avinom Learner, whereby if the survivor or caregiver is coming on the program, then the initial few sessions is subsidized. And after that, there is a negotiated rate for the patient who is willing to continue with the mentoring and coaching. I think for the person who asked that question, I can give my contacts and we can be able to get in touch later. I'll type that in the group. Thank you.
Okay, that will be helpful, Brenda. There's a question, I think 2 questions that we're talking about turnaround time from diagnosis to treatment. And someone also had talked about the fact that even when we are talking about late diagnosis or delayed treatment instituted, there are factors that would affect that. So Francis asks, can you comment about turnaround time from diagnosis to treatment and comprehensive treatment centers?
Wow, that's a complicated question to answer, because if I was to take you through the 3 patients that I did mention as part of our journey, there was Martha, because Martha has healthcare insurance and it's a good cover. She has a workspace that is catering for her treatment. She doesn't have to worry about finances with the type of clinician, the type of specialist that she has to see, the type of diagnostic test that she has to see. Martha could have anything between 2 weeks and 3 months, and she's treated fully. In fact, I'll give you an example. Just a month ago, we started navigating a patient who has been treated for a cancer from diagnostics through to treatment in 1.5 months and out of hospital already. Yes, because there is a financial backing. Let's go to Otieno, who has to sell land, and we know how long it takes to sell land in Kenya. From the moment their diagnosis is made to treatment could even take about 6 months to a year for them to secure the resources for them to be treated. Beyond that, we have the lady, Wanjiko, whose husband has left, only source of income, and the NHIF card, National Hospital Insurance card, was in the husband's name. Imagine the journey that woman has to take. And so regrettably, I think Francis is the one who asked that question. We do not have a clear-cut turnaround time from diagnosis to treatment, and even pre-diagnosis, the number of visits that have to be done before this person is told you have cancer. We've seen data come out of Kenya that shows that a patient can go even through 9 clinicians. That means 9 clinical visits before the diagnosis is made. The case that I mentioned earlier, the person who was being treated in 1.5 months, it had taken 2 years for them to be diagnosed with cancer. So again, sensitizing the healthcare worker at the level 1, 2, and 3 to be sensitive to it could be cancer, so that diagnostics are fast-tracked, would minimize that turnaround time for the patient. And of course, providing for a healthcare system that has better diagnostics in terms of financial, so that we reduce that as a barrier, would make it easier. The second question he asked was about comprehensive cancer care centers. Again, another anathema in the African space. And I say this because regrettably in the public sector, we have very few. And in fact, there are some countries that are represented here today, like Zambia, that currently don't have treatment centers. So a woman, in fact, some of the advocates that we work with have raised the concern that they're being told, don't create community awareness because then we don't have the capacity to treat. How do we live with ourselves like that? What can we change? So yeah, thank you.
Thanks, Benda. I don't know if Prof. Abinya is still with us. I'd like him to help with this next question that is from his experience. The question is, what's the percentage of cancer survivors in Kenya when the stage of cancer is 4 or more? Sorry to ambush you, Prof. Abinya, if you're with us. What you could enable him speaking so that we can have that feedback. But Benda, you could start with your experience, and then we would have the experts' experience on the same. So, what is the percentage of cancer survivors in Kenya when they are at stage 4, advanced cancer?
So, Esther, I will answer this question pragmatically. When I started, I mentioned that we have very clear data coming from the US that says 16.9 million surviving cancer in the US annually. In Kenya, we can only extrapolate with the data that we get, that if 42,000 are being diagnosed and 28,000 are dying annually, it means we have 14,000 survivors in Kenya. But the scientists on the call will tell you that is very flawed thinking when it comes to saying about data and saying about survivorship rates. The one thing I would say, there is hope. Let's not give up yet. The reason being, with more community education and more community awareness, we are getting more people coming to get screened earlier, especially in the Kenyan case. When more people come to get screened as early as possible, we have better outcomes for our patients, and therefore we are seeing more survivors surviving cancer. Can we then start harnessing this power of the survivors to get them to understand better treatment, to get the community to understand the earlier detected, the better outcomes? And I think I'll stop there so that I can give Professor Abinya an opportunity to speak. He's my mentor, and I'm happy that he's here to answer that question scientifically. Thank you.
All right.
Hello. Hello, can you hear me?
Yes, we can.
Yes.
Karibu.
Yeah, thank you. I think I must say Brenda gave a good talk. The answer as to how many survivors do we have in Kenya, is that the question?
If the question is survivors who are at late stage, that is it. But you can also add in terms of your experience with cancer patients and survivorship.
This will be speculation. You know, we have different types of cancers.
Yes.
And there are most cancers diagnosed late are going to be difficult to control. Diagnosed early, a good percentage are controllable and are curable. So when we talk about how many survivors of late stage cancer do we have in Kenya, I must admit I do not have an answer until such a time that we shall have had enough data, and not enough data for all cancers because that is impossible. But we need to have data for breast cancer, cervical cancer, ovarian cancer, and what have you. Then when put together, we shall be able to answer that question. Otherwise, I'm sorry, I cannot cheat you. That I'll answer it.
Thank you. Thank you so much, Prof. Thank you for Thank you. I think we are back. Thank you so much. I'm sure our take home, even from the specialists, we're looking at prevention, and there are cancers that can actually be prevented. And Women for Cancer has really been advocating for eliminating cervical cancer, and Benda has also highlighted the same. So we have low-hanging fruits that we could start with. Screening, we have the HPV vaccination for girls. So we could start and leverage on that. Once someone has a cancer diagnosis, now walk through early treatment, follow-up, and care for the patient and the family at large. For survivorship, the aspects Benda has talked about that would help a patient have a meaningful life beyond cancer. So it's not just looking at the diagnosis, but looking at the person holistically as a total person. Thanks for that feedback. Benda, there's a question about does Kilele have a pediatric survivorship program?
So thank you for that question. Regrettably, at this moment, no. However, and this is now the power of networks and the power of collaboration. We have one of our participants for 2021 is actually working with us and climbing the mountain with us. He himself is a cancer survivor, a childhood cancer survivor. We have 2 cancer survivors who are childhood cancer survivors in the Kilele 2021 challenge. But the one I'm speaking about, and he knows himself, and if he's on this call as well, it's to look at how do we from next year be deliberate about involving childhood cancer survivors towards advocating for the rights of childhood cancers. And we can't be everything. So our call to the people represented today is, if we can look at partnerships that build value, For example, as Kilele, we are happy to open our platform to others who would want to run with a specific element of survivorship. As Kilele, we know of other organizations that are doing other different post-treatment activities, and we can link you with them so that we're ensuring that there is knowledge and power, and the survivors, the caregivers can continue using them. We do not believe in silos. We believe in partnership for us to deliver. Thanks.
Thank you for that, Benda. And remember, we are saying this is work in progress, and the reason we keep having these webinars is for us to network, for us to see who's doing what, because again, you can't stretch yourself too thin. You can focus on what strengths you have and partner with others or other aspects that you might not have strength in. So whoever asked the question, if you have leads on also pediatric survivorship, please feel free to reach out and we see how to work together. And I know Kilele is also open to that. And we keep growing and improving our cancer care and post-survivorship. There's another question, Benda, on the Kilele challenge, the hike, or rather, who is it open to? Who is allowed to climb?
I would say, so for the first 2 years, for us, it has been a pilot. One, because I remember one of the survivors who climbed last year, when she asked me, had you done this before? And I said, no, we're learning together. She actually used the word, you're nuts. And I agreed with her that we've agreed to continue doing the Kilele challenge beyond the first year is because we saw the benefits that came from it. And so year 2 has been a very deliberate small team, 20 in number. Year 1 was 11 survivors and 1 caregiver. Year 2, we are 20 with a crew of 5. And we also have a larger crew because every survivor will go with 2 porters or 2 experts in the hiking journey so that we ensure safety of our participants. In year 3, going forward, our target is by year 5, we have reached 150 survivors and caregivers with the experience. Beyond the experience is to reach as many people with the trainings, because that's where the power lies. So my first ask is, kindly, I've already indicated we have the Kilele Health Symposium. We will have series of experts who will speak to us on survivorship and who will be there to encourage, to empower, to educate the survivors, caregivers, and clinicians on survivorship. Would it be possible for you to register? I'm going to post on the group right now, on the chat right now, the link, so that at least you can register and be able to attend. If possible, let's attend this symposium. That is where also we will get the contacts of the persons who have attended, and they will continue to be given more information regarding the Kilele programs. And with the next year's programming, we can see who can possibly join the team to also hike with us. And yes, it's a fantastic activity to engage in. Even I, as a caregiver, have benefited from the physical fitness, from the mental wellness, and from understanding better quality of life, even in the choices that I make personally. So it's not just about survivors, it's caregivers, and in anyone who has watched a loved one go through a cancer journey, or a community member, a workmate, you're welcome to join Kilele. Thank you.
Thanks for that. And I think I have 2 more questions as we wind up. Thanks for putting them in the Q&A box. There's a comment, question, and I agree with it. Thanks, Benda, for the amazing presentation. If palliative care starts at the beginning of the diagnosis, the percentage of survivorship with improved quality of life increases, isn't it? And we all agree on that. And also adds that early diagnosis depends also on awareness and increases the number of survivorship and quality of life. So Pranab, we agree with you, and as Kehpca, we also advocate for palliative care starting at diagnosis, just because there are many dynamics that affect someone with such a difficult diagnosis. So you cannot say you will wait until the end, or when the oncologist says there's nothing else that can be done, which is really a comment that has been coming up many times. So if we can advocate for palliative care beginning at diagnosis, all the way, depending on what trajectory the illness takes, you improve your survivorship chances. Brenda, there's a question about, you could answer them together. Are there any legal considerations in survivorship? And then how do we differentiate between advocacy and activism? So we can start with the legal, then the differentiation.
Fantastic, fantastic questions. So the first one on the legal considerations. Yes, there are legal considerations in survivorship. For example, if someone has lost employment, formal employment, or is discriminated against because of their cancer diagnosis, that is grounds for a legal suit. The second one, if someone has a spouse who has deserted them because of a cancer diagnosis, again, that's ground for a legal suit. The biggest challenges come in with the legal costs that come with seeking redress for the issues that they are facing. And therefore, I want to draw our attention to some of the organizations that have free services or can be able to provide. Kehpca is one of them, okay? We can actually, I'll post links to the chat as we're going along. Organizations, FIDA is one of them, Kehpca is another. They offer legal assistance for people to explore if they have grounds for seeking redress legally. And that is part of advocacy, because the more people know where they can seek services, the more it will act as a deterrent. If somebody knows I can be sued for being for discriminating against a cancer patient for whatever grounds, it's important that people know their rights. And the biggest right, of course, is the government of Kenya says that we have a right to the highest attainable quality of health. So if it's not being provided, again, we the people could sue the government. Please don't quote me. You may quote me, but it's the truth. And therein comes the element of advocacy versus activism. And I'll use an example of one of my mentors posthumously, because they say experience is the best teacher, but it doesn't have to be your own experience. The case of Wangari Maathai, and by the way, she died of a cancer diagnosis, and regrettably, it was discovered rather late in the hour. Wangari Maathai, we know her for environmental advocacy and activism. For the longest time, she went across the country getting women and men to plant trees. And at that time, it was seen as the woman who helps us plant trees. That for her was community engagement. At policy level, she was sitting in the Ministry of Environment. At policy level, she was working with parliamentarians to bring the action, resources, and budgetary allocations towards greening Kenya through the Green Belt movement. But there is a time you will remember that she and a number of women actually went to the streets and stripped to prevent Uhuru Park from built up. If you recall that from the Kenyan perspective, you would know the difference between advocacy and activism. Advocacy is where we are engaging with the constituents in dialogue towards improving. So we are giving a voice to the voiceless. We as cancer patient advocates are representing at the highest level possible for the patient's voices to be brought to the fore. However, If there was a need for us to go to the street and put up picket fences and to say that this needs to be done, we would. Only if we've exhausted the dialogue card. And so my ask of all of us on the table today is, let's think about, how do we dialogue with our government? How do we dialogue with our county governments? How do we dialogue with the various organizations on the table to ensure that we are taking the patient's rights to the fore? And so that before we go to the streets to scream and shout and say cancer is, what was the word that was used? Before we start picketing for cancer, have we exhausted all dialogue and all public participation and all petitions to Parliament and all other avenues for dialogue, including sitting on technical working groups where these policies are being made, so that we ensure the voice of the patient is being heard? Only when we've exhausted can we then say we go to the next level of activism, or when we need the voice to be louder, that's when we actually do activism. And you will remember the Black Lives Matter movement, which before then, they had been talking that Black Lives Matter, but until activism came in, did we start seeing major change. So at the end of the day, it's about a balance between policy dialogue and activism on the streets. Thank you.
Thank you for that comprehensive feedback. And I think now we know who are activists, who are advocates. I hope we can be advocates first. I'd like to request Sydney. Sydney, if you can hear us. You could unmute and make your comments. But as he does that, there are many comments on the chat. Benda saying thank you for the talk. It was very informative. Others talking about palliative care needs to start from diagnosis, supporting patients, and also palliative care providers do this work. Then the fact that families also have to be supported in terms of, if you're talking, you talked about sexuality. So if the lady has cervical cancer, the husband also has to be involved in those discussions. So it's not just one person, there are other people who are attached to this specific person. There's also,
Hi, can you hear me?
Yes, okay, you're here. Please, Sydney, make your comment. There were questions about pediatric survivorship, and you also had a comment from your end. So I've given you a chance to speak even as we wrap up this session. Karibu, Sydney.
Thank you very much. I am the childhood cancer survivor that Benda talked about earlier. Basically what we're trying to do in terms of pediatric survivorship, as has been said before, there's not enough data to support, even adult survivorship in Kenya. So what we're trying to do is to partner with Kilele Challenge and the Kilele Health Initiative to ensure that the rights of survivors across the board, from children to adults, are taken care of. For example, we had an event this weekend where we were invited to raise awareness about childhood cancer. And we thought it was a good opportunity to bring Kilele Health Association with us, because it was a free medical camp. So it's not just the rights of children or cancer survivorship with regards to children that needed to be highlighted, but cancer survivorship across the board. So there are places where, yes, we definitely need to work together and partner to be able to do certain things. There are places where, for example, some of the things that we are doing are not in line with each other. But at the end of the day, the best thing we can do is put our hands together, put our heads together, so that we have a stronger voice to be able to better advocate for patient rights, for survivors' rights, and ensure that we make the survivorship journey a holistic journey. When you come to the 4 pillars of Kilele, it's a very holistic journey, and I'm one of the people going through the mental awareness. I'm climbing the mountain with them. We are involved in community engagement. We are involved in different areas of advocacy. So it's only through these partnerships, like for example, the NCD Alliance and other organizations coming together, that we can be able to be a bigger voice so that the decision makers and the policy makers actually invite us to the table and realize that what we have to say is important. So for me, that is my take home. We all need to work together, even though we are doing completely different things. There's strength in numbers. That's it from me.
Thank you. Thank you so much, Sydney. And we appreciate the work you're doing also to improve pediatric cancer care in the country through Hope for Cancer Kids. And also, I've seen comments from people who've gone through the Kilele challenges and saying how it has been beneficial to them. So I think we'll stop there for today. The conversation continues. Please let's engage through the contacts that Brenda has also shared on the chat. We'll also be uploading them on our social media platforms. Feel free also to get in touch with Kehpca if you need further information or collaboration aspects. And we also appreciate the ministry that is also doing a lot in terms of improving cancer care. And we can also be part of those TWGs that inform a lot of these decisions that are going to be made and to improve our quality of life. So I'll give this opportunity to our director, Ms. Maculin, if you are still with us. Please go ahead and move a vote of thanks even as we close this session. We shall be sending attendance certificates within the next 2 weeks for those who are asking about that. And if there's any challenge with that, kindly get in touch with us. The contact, someone is saying, please repost. So we could repost as well as the organizations that were going to be helpful in case someone needs further support. So thank you so much. We will be having our next webinar in 2 weeks. And if anyone has suggestions for topics that we should tackle, suggestions of speakers you have in mind, please go ahead and share them with us and we will be glad to have them on board. Brenda, thank you so much. Maculin, karibu sana.
Thank you so much, Dr. Mwinga. Thank you so much for a well coordinated session. I've learned a lot, and thank you so much to our participants from all over the world for taking time and being patient up to this time. And finally, thank you so much, Brenda. I first met you at the IOTIC in 2019, one of the session, and I remember watching a video about survivorship, people at stage 3 cancer getting well, and I didn't know that they will continue up to this moment. So thank you so much. You're such an inspiration, and you're bringing up something which is very, very important that people forget, that after the disease process and going through the health facility, there's still much more to life, and we need to support each other. We need to support survivors to live as much quality life as possible. So because of time, I want to release us, and thank you so much for attending. And we look forward to more engagement and continue supporting more survivors. I know these survivors, they're not far away. They are our sisters, they are our brothers, and even they are us in one way or another. So thank you so much, and God bless. Have a great afternoon. Oh, it's evening in Kenya and afternoon in other places maybe.
Thank you.
Thank you.
Thank you so much.
I don't know the time in India, that might be different. Yeah.
Yes.
Okay.
Thank you.
Thanks, everyone. Have a blessed time.
Thank you. Thank you so much all.